First of all, I just want to thank all of you for having me today to do this little talk. And again, my name is Marguerite Johnson. Thank you, Dr. Hannon, for that introduction. I've had the pleasure of working with both Dr. Hannon and Dr. Gross. So I know they'll steer me and correct me if I go off track with any of my talks. So thank you again for sharing a bit of my background, and not to belabor it, but before I came into transfusion safety, as Dr. Hannon alluded to, I was a bit of an adrenaline junkie in terms of my clinical trajectory, certainly working operating room, emergency trauma, and labor and delivery. But a really important part of my talk today centers on kind of a broader vision of patient safety and touching on a couple of points around error science. And that's really important because I feel like really the science hasn't really extended all the way into transfusion medicine. And so I'm going to touch on that a little bit as well. So let's just get right into it here. So I do not have anything to disclose, although I am working on it. So we'll see if I can get there. So some of the goals of the talk today are really, again, to talk a little bit about prevalence of medical error as a backdrop for transfusion safety. We'll talk a little bit about the Transfusion Safety Officer role and some qualifications. We'll talk a little bit about the difference between transfusion safety and patient blood management, and really kind of the role has evolved a lot into the patient blood management world, I would say, from its genesis. We'll talk about prioritization strategies when establishing a blood management program, and we'll talk about how to deal with difficult physicians. And neither Dr. Hannon or Dr. Gross are difficult physicians, but certainly I know they have wisdom to impart here as well. So let's talk about how risky is healthcare. Well, as it turns out, it's very risky. I can tell you when I first started in patient safety exclusively, and certainly more broadly than in transfusion safety back in 2004, there was a landmark paper by Lucian Leap out of the Institute of Medicine, and many of you will have heard of the 100,000 Lives campaign. And at that time, that seemed shocking. So that was equivalent to a jumbo jet crashing every day with the number of patients who died related to medical error. And more recently, in 2016, a paper out of Johns Hopkins estimates that's more likely to be closer to 250,000 people that die from medical errors. So we can double that to 2 planes crashing every day, which is shocking. If we heard that on the news, we would certainly be startled. And the third leading cause of death after heart disease and cancer. So there's been a ton of work done in patient safety, and yet we're still having this issue. And certainly, I think what we need to understand about this is that it's really about the design of the care, and that is why we have the issues that we have. So we're talking about design of the care pathway and structures and barriers to prevent harm. So many of you will have heard of the James Rees and Swiss cheese model, which you see on screen. And essentially, what that says is that we have hazards that slip through multiple different layers of barriers because there are latent conditions kind of sitting in wait. And when those hazards get through all of those barriers, that's how patient harm occurs. I want to kind of share with you a story that happened to me early on in patient safety as an investigator. I got the privilege, again, in around 2004 of working with an anesthesiologist who came from the aviation world and was responsible for doing a lot of investigations in healthcare medical harm events. And one of the first ones I got to work on with her, and her name was Dr. Jan Davies, was a what we call a fatal dialysis error that happened in Calgary. And this was an issue where there were 3 patients who actually died from dialysate, or dialysis fluid, that was compounded with potassium chloride instead of sodium chloride. So when you go back and look at this event, you will see it was actually just a series of very minor errors, similar to that Swiss cheese event. But of course, because 3 people died, and this is an excerpt from the article in the paper, you know, it's like this. They described it as dying of the most dreadful medical mistakes ever revealed in Alberta or all of Canada. And yes, it was, because 3 people died, and that's absolutely a terrible thing. However, when you look at the root causes of that, there are numerous things that lined up. And this is just one of them. So this is the look-alike, sound-alike error that can happen. So what you see here when we did this investigation is when the pharmacy compounded the dialysate. You can see that on the left here is sodium chloride and on the right is potassium chloride. They look almost identical. And then there was a selection error that occurred with just selecting the box of potassium chloride on the right from the box of sodium chloride on the left. So there was a series of minor selection errors and minor documentation errors that resulted in patient harm getting to 3 patients and causing 3 fatalities. And I think it's just, again, underscores the fact that, you know, if we took out all of what we think were the bad apples in healthcare, be it in the lab side or on the clinical side, you would still see these errors occur. And so that should always really be the backdrop of when we're looking at transfusion safety and fixes to make transfusion a safer care process. We should be thinking in a systematic approach. So this is a summary of a study done by Nolan, and this is pretty old. This is back in 2000. So this is just looking at error science and error rates, and especially looking at types of error by specialists in human factors. So there's a list of different errors here and a probability of human error in this work. And you'll see here there's different types of errors such as commission, which is misreading a label, 3 in 1,000. Omission, absence of reminders, 1%, so on and so forth. You'll see them go down the list here. They're fairly low in probability, but still they happen fairly commonly. But when we go to this last category of general error rate, given very high stress levels where dangerous activities are occurring rapidly, we have up to a 25% error rate. So again, that's why the mechanics of care and design of the care is so important. And so as my mission, I would really like to see us embed this work more into the transfusion side of things. So let's jump now into transfusion safety as a role. So I think that actually this role did start in Canada, and Dr. Gross, you can correct me if I'm wrong, but I can tell you this was ground zero, and in fact, in the years of 1993 to 1997 in Canada, following the quote-unquote tainted blood scandals of the 80s, where patients received HIV positive and Hep C positive blood products, there was in Canada something called the Crever Commission or the Crever Inquiry, which evaluated the whole blood system and tried to find faults and correct errors, etc. So that is where actually Canadian Blood Services became a national program. It was taken away from Canada Red Cross. So that's a different trajectory than here in the States. So a new blood kind of body was created. But one of the key recommendations was the creation of this brand new position called TSO, or Transfusion Safety Officer. So there was a finding that on the hospital side of things, there was not a good ability to look back, trace back to promote transfusion safety. There was a gap between the lab and the clinical side of medicine. And so that recommendation was actually in that inquiry. In as early as 1999, those positions were grant funded in the province of Quebec, and there was 20 plus folks of various backgrounds that underwent extensive training in hemovigilance, transfusion reaction, error management, etc. And they found that shortly after that, there was an 80% increase in reported reactions. Currently, there's probably over 80 transfusion safety officers across Canada's 10 provinces. They're a blend of nurses and techs by background, and there's a link here. I would encourage anyone who's doing the transfusion safety officer role to write down. This is www.transfusionsafety.ca. All this is a listserv, so it links you into that whole network of folks. It's free. It's not any kind of promotion or anything of that nature. It's really just to be linked into additional resources. So you've got 80 people there that if you're starting a program and you're not sure what to do, you've got some really good resources with a lot of experience. So if we go down now to our little part of this experience. So this is a bit of a busy slide, but we were late to the game. So we're in the province of Alberta out on the west coast, and around 2006 is when there was funding to start a transfusion safety office out west. So this is a really bad picture of the odd couple that were me and my partner in crime. So on the left here is Cheryl, and she was out of the blood bank. And this is Cheryl's world. Cheryl is a senior blood bank tech, over 25 years of experience, deep technical knowledge, leadership and quality initiatives. She just knew it all. And this was her world, nice and neat. And then this is Marguerite over here, the nurse from the chaotic world of clinical medicine. Certainly worked in the blood specialties, had some training in Six Sigma and safety methodology and operational leadership roles. What I would add here is this is what I was used to. I had a comfort level with this and not so much with the neat world of the blood bank. I think this was a perfect partnership in retrospect. So if you're sitting in the room, and whether you're a lab tech by background or a nurse, I would strongly encourage you to find that opposite yin and yang position because it balances you and it teaches you many, many things. So I added at the bottom here, kind of tongue-in-cheek, that as a nurse, I thought I had deep blood knowledge by osmosis, or by, well, probably not osmosis, but by getting blood all over me. And Cheryl kind of came to that role with she's going to teach these nurses and physicians a thing or two because she's tired of the fact that they certainly don't seem to understand some of the issues around blood transfusion. So I think I've learned everything from healthcare business from Dilbert. I think there's humor in everything. So this is just a quick comic. So this is Dilbert talking to his boss. Your user requirements include 400 features. Do you realize that no human would be able to use a product with that level of complexity? And the boss says, good point. I better add that to the easy-to-use list. So really, again, the underlying thing here is making the safe thing the easy thing in terms of what we do. So this is something that I think is really worth remembering. And this is adapted from the Institute of Safe Medication Practices. And this is a hierarchy of safety solutions in terms of effectiveness. So at the top of the effectiveness, actually, let me start at the bottom, because the bottom three are what we tend to really focus on: rules and policies, education, and information. More information, we've got to tell people that they're doing things wrong, and so on and so forth. And actually, while those are important pieces that we can add, they are not very effective. What is much more effective is forcing functions, standardization, automation. So we heard Dr. Gross talking about kind of hardwiring patient blood management into the electronic health record. That would be a very important and effective way to hardwire the safe thing into the system. So just keep that in mind when you're, as a transfusion safety officer, when you're crafting solutions. Think about, okay, I can't sit down here and I can write a nasty note or I can come up with a new policy, but is there a better way to do this where I can hardwire this in and make this a little more of a default way of practicing? This is just a really high-level overview. When we started with the Transfusion Safety Officer back in 2006, so I had some of that design and safety, human factors background, and so some of the projects that we started out with were things like informed consent. So we created a lanyard badge with kind of the risk, benefits, and alternatives, because as we tried to dig into why physicians wouldn't do informed consent, we realized that they often didn't have that information at their fingertips and were often not comfortable having that discussion. So that was one thing we tried to come up with. We did a project where we redesigned our blood labels because as part of our audits and so forth, as we were learning kind of what our opportunities were, we realized that we had very difficult to read labels. And this was before barcoding. So we had a human factors engineer come in and redesign all the labels so they could be read and double-checked more appropriately. We got rid of things like trailing zeros and things that were sources of error. Then we created kind of tools such as this acute transfusion reaction flow sheet that was symptoms-based for nurses rather than kind of a list of reactions in a binder and trying to sort out what was going on with the patient. We tried to start with, are they febrile? Are they hypotensive? What does the clinical picture look like, and what could that reaction be? So those were some of our early projects. We also started a perioperative blood conservation program, and very simply, we just kind of added ourselves onto the pre-op assessment clinic, where patients are evaluated by the anesthesiologist or internal medicine physician prior to surgery for their suitability for surgery. And if they were anemic, it was a straight referral to us, and we worked them up as the nurse team and corrected their anemia. We were fairly successful most of the time prior to surgery. Those were our big early projects. And then this thing called patient blood management kind of came along. And so I'm sure you've probably heard mention of 1999 and the landmark trick trial, which kind of really was the game changer and really started the ball rolling with more and more clinical research and randomized controlled trials. And that started to kind of find its way into transfusion safety. So we found ourselves kind of making a bit of a transition from transfusion safety, not leaving it all together, but starting to integrate in patient blood management. So there's a lot on this slide, but essentially transfusion safety is really, looks at certainly reactions and things like TACO and trolley recognition. Those are way more common than we used to realize. And in fact, the non-infectious risks of transfusion are much less than what we used to think. And that's still under the auspices of transfusion safety. And of course, so are all the regulatory issues, consent, audits, practice, look back, trace back. But then we had to integrate in all of the literature related around patient blood management. This is more of a transformational piece, which for us meant we had to get out in front of physicians and nurses and start to share what the literature was telling us, that less is more, that a restrictive approach to transfusion is probably better for our patients. We had to start to think about how to measure our performance. And do we have a standard set of guidelines by which, we can all follow and agree upon? Have we thought about anemia management and how can we improve it? And how do we manage bleeding? Do we have protocols? Are we using the appropriate pharmacological adjuncts that are in the literature? Point-of-care devices such as TEG or ROTEM. So all of that was then added into what became a very big job. It became the Transfusion Safety Officer / PBM program from that point on. So by the time we kind of took it up, that's where it was. So I know patient blood management has been discussed. I'm not going to go into significant detail about the science, but I think there's two key points just to always be mindful of, is that blood is both pro-inflammatory and immunosuppressive. So yes, it saves lives, but we need to give only to those patients who need it and with a minimal effective dose. So that takes us into the risks of transfusion being dose dependent. So again, the concept of minimal effective dose, much like medication, is what we need to be thinking about. So, and I'm sure this is a chart from Ferraris that you've probably perhaps seen already this morning, but even 1 to 2 units can add risk of mortality and composite morbidity. So those are those two kind of key points to always keep in your hip pocket as a transfusion safety officer. The other thing just to touch on briefly is the true cost of blood. So there's a couple of different sources in this particular slide. The first was a study done in 2010 which looked at the cost of blood products, but also the activity-based cost. So as nurses, as techs, we know that that takes time to kind of cross-match those units, to prep them, to dispense them, for the nurses to transfuse them, to monitor the patient. So that is actually about anywhere from 3.2 to almost 5x of the cost of the blood itself. Then the Health Management Council came out with a study in 2010 and said the cost of a hospital-acquired infection is somewhere in the range of $24,000. And so that actually is a lot more than the cost of blood. And as we know in this world of value-based care, often those events are not reimbursable to the hospital. And in fact, you may or may not know that often the first 2 units of blood transfused to inpatients are often not reimbursed. So we're here for patient care first, but healthcare and hospitals are a business as well. So we need to be really prudent about wasting resources, especially if it's potentially put patients at increased harm. So I know that you talk a lot about high-value care or value-based care. And so patient blood management really is a 3-pronged monster in a good way. We focus on right patient, right care. So again, blood is not necessarily bad and people need blood, but anemic patients can be managed differently, as Dr. Gross spoke about. Better patient outcomes. So we know that we have less complications, shorter length of stay, and less patient harm when patients are transfused or managed according to evidence-based practice. And then finally, lower savings. So again, important information, and certainly for the hospital administrators to understand as well. Value-based care is becoming much more prominent. CMS had mandated that by 2018, 80% of reimbursement should be by value-based care models. So I don't think we're going backward, but it's that brave new world that we have to figure our way through. So let's transition now. We're going to talk about getting your program up and started. So some of you may have heard of Simon Sinek. He has a very popular TED Talk called The Golden Circle, and that's what this slide is referencing. This is always tap into your why. So before you kind of even get out there in the trenches, start talking to people, start telling them what you're doing, you need to connect with why you are doing this work and why this is important. Not that you were just voluntold to do some position and you're like, man. But why do you do patient safety in healthcare? What is your why? And that is your inner purpose. I really feel like if you can connect to that, when you communicate with physicians and nurses, they will really get your passion, and that stands for a lot. It's not just an exercise or a box-ticking sort of thing. This is we care about patients. So really connect to your story as to why you do that. So this is my why. I'm going to harken back to Cheryl, who was my partner in starting our Transfusion Safety Office back in Canada. So Cheryl, in fact, back in the 80s she was one of the people who received plasma that was contaminated with hepatitis C virus. And she's been valiantly doing this work for a long, long time. You can see her dogs here. She actually breeds Finnish Lapins, which is a type of, I guess, kind of a husky dog. Very passionate about it. And Cheryl, over the years, shared with me, as she was receiving interferon treatments, that this had happened to her and that she had received this tainted blood back in the 80s. And part of that Creever inquiry I mentioned was that there was a test for hepatitis C available, but in Canada, at least, they were very delayed on implementing that. And so she was one of the ones who contracted hepatitis C because of a failure to implement the test to detect that. This is Cheryl a couple of months ago. Cheryl now has liver cancer from her hepatitis C. She's been through over 20, 30 years of interferon and other different treatments trying to fight the hepatitis C. And so Cheryl is my why. She is, a soldier in this, and she's the reason why this is important to me. So I always connect into Cheryl when I talk to folks. So that being said, probably the first step you would want to undertake as a new transfusion safety officer is to assess your opportunity. So I harken back to Dilbert. All good things come from Dilbert. So Dilbert's boss is saying, from now on, we will refer to all of our problems as opportunities. And I know in healthcare, we hear that a lot. And then the secretary comes in and said, one of your idiot spawn was playing with the oven and burned down your house. And somebody said, camping opportunity? So there's our opportunity. And this really is an opportunity to really improve the safety of patients. So this is a little busy, and it might be a little hard to see, but essentially what this is a template for a program structure. So the key first step is really to evaluate your opportunity. So some of the key inputs to that are understanding the current state. So who are your high transfusing blood specialties and physicians? Are they compliant with current guidelines? Are those guidelines even current? You may need to look at that. Utilization oversight. So are we wasting products? What's our inventory kind of issues? And regulatory requirements. Are we doing consent? Are vital signs being monitored appropriately? Are we reporting reactions? We would expect about a 1% incidence rate of transfusion reactions, So if we're not seeing anything being reported, then the nurses are under-recognizing or under-reporting. So we need to do a little bit of a current state assessment. Kind of overlapping that is implementing some of the program basics, and I'll show you a different slide on that in a moment. But this is kind of your key 4 priorities for getting things up and running. Once that's up and running, you're going to do a scale-up and maturity process, and that could take several years to kind of complete these steps. But that's the general sequence of them. Dr. Hannon, I think you're sharing the slides after this, so I think it'll be easier for people to read it if they have a copy. So let's just talk then about what are the big priorities if you're going to implement patient blood management. So I think there's 4 key ones. And the first is really get your data up and running. So it's going to be really important when you speak to physicians to give them some sense of measurement against some key performance indicators that they can kind of grab onto and get used to. Because once you understand what your baseline performance is on several key indicators, then you can set some goals with your committees and so forth to achieve improvement. So that's one of the really important things, but underlying all of that is data, of course. So once you have that data, it's going to be important to create reports. And certainly a physician scorecard or the notion of that is quite important in terms of ranking physicians. And that's, as we all know, physicians are competitive and they don't want to be that guy or girl who is not following the guidelines or is an outlier in their practice. That's really important. Communication plan. So once you kind of do that assessment, you've got to kind of understand how you're going to communicate. I think you can keep it pretty simple here. You can have 1 or 2 key presentations that are brief. If you need some kind of technical input from someone to kind of buffer up your technical knowledge, then by all means do that. But then my second order of business would be to talk to the communications department about opportunities to communicate throughout your organization. It might be a newsletter. It might be a link on a web page. Utilize all of those internal resources to start to communicate your program. In the bottom left is new clinical guidelines. So again, you'll have to make sure that yours are current. And you'll want to utilize things like hopping over to the right, a transfusion committee or some sort of steering group to help kind of vet those. But that will be an important thing because that is kind of the rules of the game. And we have to come to a shared agreement on whether or not, what is acceptable and what is appropriate to follow. So there's some excellent guidelines, well published and easily available through both AABB and SABM, Society for Advancement of Blood Management. And then the next step with guidelines will be, as Dr. Gross mentioned, to engineer those into your EHR. And then finally, build your infrastructure. So again, if you have a transfusion committee, take a really good look at it because it may have kind of morphed into a committee where you have 2 or 3 people who always show up and you check a few boxes about CT ratios and waste, etc., and they leave. What we're really aiming for is a multidisciplinary, robust clinical committee. So we need representatives from physicians, nurses, lab, pharmacy down the road, really important. Is your quality person integrated into that work? And are you integrated into the quality department? So those are all really important components of the infrastructure. And so that will be a key piece of work. If there is not one started, you'll want to consider starting that with a few key leaders. And if there is one and it's inefficient, you'll need to kind of retool that. So those are the 4 priorities to really get things up and running with the program. So I think just important as the mechanics of a program are you building your credibility and building a program and your credibility quickly. And I think there's a few key points here to think about. The first is learn and learn quickly. So there's really no substitute for knowledge. And it's okay not to know, but don't you dare go to a committee and pretend to know the answer and try to, fluff your way through it. I promise you, everybody will sniff it out, and you will lose all credibility. So it's okay to say you don't know the answer, but you have to kind of bring yourself up to speed, especially for nurses. Nurses, we are not trained on the technical side of this. And so for me, I will tell you, I immersed myself in the blood bank like every day. I wanted them to show me how to do an antibody panel. I wanted to understand how you type and cross-match. I wanted to learn it all. And that gave me the ability to go and talk to my colleagues and have a point of reference. It's highly important. Focus your learning, so you don't have to learn it all, but, following the 80-20 rule, if you have kind of a small solid group of studies and literature and you understand that really well, that probably will cover 80% of the knowledge you need to have. So start there. Get in the trenches, as I said. Really, if you're a lab tech, then go down to the emergency room. Ask to hang out in the operating room when there's a massive hemorrhage. Learn the other side of the ball. It's really important. Find key people to show you how. So again, you're a group of people in the room. You have Dr. Hannon. There are people out here who have done this work and can help you. So tap into them. Do your homework. So leverage your experience. Not to belabor this too much, but the long and short of this is you have to find a few physician champions and key influencers. They may or may not be a department head, but when you look at their initial data, you'll actually be able to see, well, look at Dr. Smith over here. He's doing really well on these performance indicators, and people listen to him and follow him. Those are the sorts of people that you want to bring on board and kind of get them in your corner. Ask lots of questions and use established resources. Again, SABM and AABB are excellent. Build your network. It's probably self-explanatory except for 2 key points. One is that you have to be anchored into the right people on the administrative side of things who will back you up. So when you have departments who do not want to follow the guidelines or individuals, you need to be linked into the right people on that side who will kind of drive that forward for you. Be a communicator. So again, I'll tell you in my experience, I went everywhere and anywhere. I talked to people in the cafeteria line. I would go to staff meetings. I would, talk to anyone. And Dr. Hannon often references scrub sink conversations. So it's really important to have an elevator speech. Give yourself a 30 seconds to 1 minute, here's why I do what I do, and here's the key things to know, and here's where you can find me. Those are just simple things, but they're really important for success. Finally, show respect. So this is a bit of a tough one as a nurse or as a MLT. When you're presenting to a room full of physicians, that can be very intimidating. So you have to be deferential and respectful, and it's a little bit weird to think that perhaps I know more on some of this content than some of the folks in this room, but you have to kind of be really smart about how you deal with physicians. You have to be deferential, and you ask them what matters to you, because that will kind of help, engage them. So they're very busy, got a lot going on. So you want to kind of learn from them, lift them up, and thank them. It's really simple stuff, you guys. But those things go a long way. Be really good buddies with people, we say it in the trenches or on the front lines, not just the administrative top dogs. That's another important point. So we just want to a couple more things to mention before we wrap up. So this is a slide about this references Rogers diffusion of innovation curve. And so you'll see, your typical bell curve here, and you'll see kind of this, a breakdown, if you will, of people who kind of pick up new learnings and implement it. And they tend to fall along this bell curve. So these 2.5% of innovators at the front, these are the people that wait in line for 3 days outside the Apple store when there's a new iPhone launch. They are there. They want to be the first ones. Then you have this group over here, early adopters, who are very much on the heels of the innovators. And then most of the people fall in this early or late majority. And then we've always got this group of laggards over here. These are the skeptics, and, they're the difficult ones to convert. But interestingly, there's a tipping point that occurs at about 16% or so, that if you can kind of find these people and get them on board with your cause, then you will start to tip the cart over, and the early majority and late majority will follow. So that is, again, the key, is to find these folks right here, the people who are already leading with their practice and who are influencers. They're really, really important. And if you can find those, you will tip it in your favor. I want to make a mention now of difficult physicians. So this was in our learning objectives. And as I started to kind of look at this question, I realized I had a lot of anecdotes, but I thought there has to be some science behind this. And in fact, there is. There's a paper published by Ezekiel in Annals of Maternal Medicine back in 2016 that actually studied the principle of behavior economics in designing physician incentives so that we can deliver high-value care. That's exactly what the paper is titled. And there's some key kind of takeaways from that paper, just to kind of cover them really quickly. That physicians, and not just physicians, but people in general, are focused on loss aversion more than possible gain. So, for example, if there is already a bonus payment or something that goes to physicians for performing well on performance metrics, just as a general, writ large sort of program, if you threaten to take some of that away because they are not performing, while that's not very palatable, according to these researchers, it is actually quite effective. So, in other words, don't dangle a carrot to do something great, but use that as kind of leverage to say, look, you're way out of guidelines, and if that continues, here's what's going to happen. Avoid choice overload. So we talked about that. We don't want to give physicians too many choices to contemplate and have to make decisions on. So this is the notion of kind of minimizing that and keeping things very simple in terms of incentives. Interim feedback versus annual performance review. So again, this is like the notion that giving small bits fairly frequently, either monthly or quarterly, on data and so forth is more effective than waiting for a year-long review. Reinforce info with specific guidance is referencing the fact that it's not just about educating physicians and nurses, but it's about giving specific guidance. So it's not just, transfusions are dangerous, but what do you want me to do? I want you to transfuse patients below a hemoglobin of 7 unless they have acute coronary syndrome. So be very specific in the desired behavior. Principles of social ranking, very effective, and this study really focuses on this. So again, the notion of scorecards and ranking and feeding into that notion of competition is actually quite successful. Inertia. So like physicians and all of us, a body at rest tends to stay at rest. So there's a recommendation to overcome that by hardwiring the default behavior again into whether it be the EHR or whatever the case may be. So we've heard that over and over again, that it is highly effective. And then create attainable goals. So there is science that says if you set a goal that's up to the moon, people are going to disengage. They'll be much more likely to kind of push towards a goal that is attainable. So just keep that in mind as well. So just let me summarize then some of the key things I hope I got across. always tap into your why first. I can't underscore that enough. You don't want to get in front of a room and sound like you just don't care. So figure out what that is that drives you and tap into that. Be a prophet, not a zealot. Dr. Hannon, this is right out of your quote book. But the notion here is that so you don't have to be absolutely, ridiculous. The idea is, get those small wins and get some momentum and get people excited about it. But you don't have to kind of hit them over the head with it. So it's an art and a science. Quick wins to gain momentum, highly important. So look for that low-hanging fruit. What is it? And get those small wins because those feel really good. It's a tough job, but when you get those small wins, it's really encouraging. Build your small coalition of the willing, I call it. So again, those key influencers, get them into a little coalition and move them forward with you to fight the good fight. Anchor to the strategic partners that can help you. Data. Share your vision everywhere. Practice radical simplification. Oh my gosh, healthcare is so complex. So wherever you can simplify things, be mindful of that. Less mouse clicks, things more visual. Anything in that realm, just make it the safe thing, the easy thing. And aim to make transfusion safety a way of being. Like that's the end goal that, hey, we are a culture of safety around transfusion and patient blood management. And that's just really entrenched in the organization. Have fun. And then I add, and get a dog because I think they help you live longer. Again, harkening back to Cheryl, that's her passion and it's helped her to live longer than she thought she would. And with that, I will pause and thank you all and open it up for any questions.